Bienvenidos a CRF News, un segmento que tenemos en colaboración con la Revista Colombiana de Cardiología. Ahora les traemos una charla muy interesante que es dada por una persona que no necesita ninguna introducción, el Dr. Greg Stone, uno de nuestros directores del TCT y gran amigo de nosotros y de Colombia, donde da una charla muy interesante acerca de la historia de la reperfusión coronaria en infarto agudo de miocardio. Esto es una charla espectacular porque cubre aspectos históricos de la parte del manejo médico y también aspectos intervencionistas y, como es bien conocido en todas sus charlas, basados en la evidencia clínica. De verdad que en un país como en Colombia, en donde el tratamiento de la angioplastia primaria es tan prevalente, tan común y tan necesario, esta es una charla que es absolutamente esencial para entender todos los aspectos históricos, terapéuticos del manejo y pronóstico de pacientes con infarto agudo de miocardio. Ojalá que de verdad disfruten esta charla y nos vemos pronto en el próximo episodio.
Okay, history of reperfusion therapy in STEMI, not only the past but the future. So this is an article that I really recommend everybody to read. It was written by Elizabeth Nabel and Eugene Braunwald a few years ago, and it documented and tried to explain the marked reduction in case fatality from cardiovascular disease over the last 60, 70 years. And as you can see, from the 50s to the 70s, we were getting actually nowhere, about 450 out of 100,000 people dying from cardiovascular disease, and then the rate started to plummet. And we really need to be proud of this. I mean, we've really made more impact in a subspecialty, I think, than almost anything since Jonas Salk cured polio. And what they did is they put all sorts of accomplishments that they think were related to this decline, just in their opinion. This wasn't randomized trial data, but this is their opinion. And a few of these are pretty interesting. A few is the development of coronary angioplasty by Grunsig, and then there's reperfusion therapy in acute myocardial infarction, first with fibrinolytic therapy, and then with the superiority of primary PCI versus fibrinolysis in acute MI, and that was from our PAMI trial, which I'm going to show you. Now, this is acute myocardial infarction. The pathophysiology, it's a ruptured, lipid-rich, thin-capped fibroatheroma, which is very inflamed, metabolically active, and when it ruptures, it exposes tissue factor and other prothrombotic contents of the basement membrane and the underlying plaque, and you get thrombotic occlusion. Now, the way to obviously abort this, we now know the obvious way, is to restore reperfusion, hopefully before the infarct is complete. And there's two ways to do that, with either fibrinolytic therapy and primary PCI. You all know that all we do now is primary PCI. But back then, okay, when I got into this, we had reperfusion wars. And this was more intense and more heated and argumentative than anything you can imagine going on right now. Fibrinolytic therapy or primary PCI. It was pretty ugly. And fibrinolytic therapy worked and was shown in large-scale randomized trials to save lives. But it only restored adequate antegrade epicardial flow, TIMI3 flow, in about 55% of patients, and it was associated with intracranial hemorrhage in about 0.5 to 1% of patients. And that was a real downflow. So primary PCI, on the other hand, is much more effective in restoring reperfusion and avoids intracranial hemorrhage. But none of the establishment, okay, whether it be Braunwald or Califf or any of the thought leaders back then, thought it made any sense at all to bring patients in the throes of an acute MI to the cath lab and delay giving lytic therapy. So it really was Jeff Hartzler, who I had the great fortune of training with when I was a fellow, who did the first primary PCI, and they published their initial results of basically 2 patients with total occlusions, 6 patients with subtotal occlusions, repeat cath at 12 days, showing patency of all dilated segments and no reinfarctions at 6 months, and most patients asymptomatic at follow-up. And this was just shocking. This led to us doing the primary angioplasty study, and I've got to really commend Bill O'Neill and Cindy Grimes, who did a lot of this early work, and we showed that death or reinfarction was reduced from 12% to 5% with primary PCI, and hemorrhagic stroke was virtually eliminated. Well, a lot of people didn't believe this, and this led to 23 randomized trials of PCI versus lysis. This is the most we're ever going to see, 7,739 patients, and it confirmed that by doing PCI, we save about 2 lives per 100 patients instead of thrombolytic therapy. By stabilizing that unstable plaque, we reduce reinfarction, and we virtually eliminate hemorrhagic stroke and therefore reduce total stroke in AMI. There's also less recurrent ischemia, patients go home sooner, they have a better quality of life, etc. And subsequent studies showed that we've had continuing ongoing declines in cardiovascular mortality, and a lot of this, perhaps the majority of this, is attributed to revascularization. You'll have a lot of people say, well, it's statins and thienopyridines and rehab, et cetera, and that's important, but at least in this analysis from the GRACE registry, revascularization makes more difference in primary PCI and even non-STEMI than any medical therapy. We also learned that time is myocardium. And one of the ways, not the only way, but one of the ways that primary PCI works is by aborting the infarct. And you're doing a large transmural infarct into a smaller subendocardial infarct. And you only have about 2 to 3 hours to do that in an occluded coronary artery before the infarct's complete. And we've seen multiple studies that the faster you can reperfuse patients, the smaller the infarct and the lower the mortality. And this led to do whatever it takes to reduce time from symptom onset to ER arrival and to PCI. So we tried to increase public awareness of MI symptoms. We created chest pain centers of excellence that had documented lower door-to-balloon times, regional coordination, ambulance ECG telemetry, ER, cath lab activations, and also from the ambulance to get the teams moving. Interventional cardiologists still at a lot of places do sleep in hospitals, and most importantly, continued QI, quality improvement, to keep showing that you are meeting standard metrics. And what happened is over about a 15 to 20 year period, door-to-balloon times, as a very important metric, decreased from about 120 minutes overall to about 87 minutes. And as I'll show you, even better now. And along with that, mortality decreased, both the patients presenting at PCI hospitals and that had to be transferred in, even though their door-to-balloon times were longer. So we were starting out at about 9% mortalities, and we got mortalities down to 3 or 4%. Now, along this, that was mostly balloon angioplasty. And along this, we've had important evolutions in both devices and drugs. And in this talk, I'm going to talk about the devices. We went from balloon angioplasty to bare metal stents to drug-eluting stents, but there was also an important evolution in adjunct pharmacology. We started out with heparin and then aspirin, initially ticlopidine and clopidogrel. We moved then to heparin and 2B3A inhibitors with aspirin and clopidogrel, and that was shown to reduce mortality and reinfarction. We then moved to bivalirudin with aspirin and increasingly potent first oral and then intravenous ADP antagonists, and now there are some people that think in the era of radial access, we can perhaps move back just to heparin. And this is very, very controversial. It would take me about 20 minutes to do justice to the topic, so we'll perhaps discuss it in other sessions or maybe during discussion. So let's talk about the devices. The problem with balloon angioplasty, as I showed you before, is you take a ruptured plaque, which has thrombus in it, you put a balloon in it, you embolize some of the thrombus, and if anything, you make the dissection worse. Okay, so that is, again, a setup for recurrent ischemia. And this led to 13 randomized trials of bare metal stents versus balloon angioplasty and AMI, the PAMI stent trial being the largest of these, along with Cadillac. And this showed overall in almost 7,000 patients that we reduced early acute closure leading to acute TVR and then late restenosis, so about a 45% reduction in TVR. But we did nothing with stents compared to balloons to decrease death or reinfarction. Then we brought in first-generation drug-eluting stents, and there were 13 randomized trials of Taxus and Cypher versus bare metal stents in more than 6,000 patients. And these trials in STEMI showed almost the same as what I showed you in stable coronary disease. There was a marked reduction in recurrent restenosis, so about another 50% reduction in restenosis. But this was at the cost of an increased incidence of very late stent thrombosis and reinfarction. So first-generation DES just weren't safe enough, and stent thrombosis is higher in STEMI patients than in any other setting. So then this led to second-generation DES trials, and again, a total of 22 trials, 12,500 patients, huge amount of evidence-based medicine in our subspecialty. With Tullio Palmarini, we summarized this a few years ago in JACC, in this network meta-analysis. You can't possibly read this slide, but what it basically shows is that statistically, cobalt chromium everolimus-eluting stents, which was the only second-generation DES in these studies, was statistically better than everything else in terms of every endpoint: death, myocardial infarction, stent thrombosis, and restenosis. So second-generation drug-eluting stents have become the standard of care for primary PCI. Probably the clearest one trial was the examination trial, the only study that randomized a second-generation DES, Xience, against a bare metal stent, and these are the 5-year results in 1,500 patients. There was a reduction in target lesion failure from bare metal stents to Xience, but no overall difference in cardiac death or myocardial infarction. The biggest difference was in target lesion revascularization. So again, what makes a difference in primary PCI is getting the artery open and restoring patency. The TIMI flow rates aren't necessarily better after stenting compared to balloon angioplasty. Bare metal stents, drug-eluting stents, it doesn't matter. So the biggest difference that we've made with DES here is reducing TLR, although there's some data to suggest that stent thrombosis may be a little bit lower because of less restenosis. Now, there have been some people who have said that STEMI success has plateaued, and this may be the case, because there's data to suggest that further reductions in door-to-balloon time below 90 minutes have not been beneficial. And part of the reason is that patients with an AMI present too late, on average, to the ER for us to do a lot. We also salvage a suboptimal amount of myocardium. Despite effective epicardial reperfusion, we often end up with large infarcts. And our true reperfusion success, as I'll show you, is only about 65%. And in part, this is due to distal embolization, in part due to reperfusion injury and other mechanisms. Mortality remains high in cardiogenic shock and out-of-hospital cardiac arrest in particular, and there's ongoing inflammation, which leads to high rates of non-culprit lesion-related events. And that's what we were talking about this morning. In patients with multivessel disease and apparently stable other lesions, those lesions are not as stable as they are in patients with chronic atherosclerosis. So this is some of the data to suggest that in the last 4 to 5 years, as we've gotten door-to-balloon times now down from 83 or 90 minutes down to about 60 minutes, there's now no further change in in-hospital mortality. And it seems this is very different than the earlier graphs I've showed you, and it seems like that we've hit a plateau. And some people say this is because we're so fast now that we're not doing a good enough job stabilizing people in the emergency room, and there may be some truth to that. But I think the biggest problem is that we're ending up with large infarcts, and we're not, that incremental reduction in time is not further reducing infarct size. So we've looked at 10 randomized trials of patients that had infarct size measured within the first week after a STEMI, and then followed the patients out to a year. And there's this very strong relationship, as you would expect, from the size of the infarct to 1-year mortality by quartiles of infarct size from less than 8% to 30% or more of the left ventricle. And this is also strongly related to subsequent hospitalizations for heart failure. Now, when you look at how we do in salvaging myocardium after primary PCI, it's not very good. If you look at global ejection fractions, this was from our Cadillac study, at baseline, acute EFs, and then at 13 months, they go up by like 2 percentage points. And it doesn't matter whether it's balloon angioplasty or stenting with or without abciximab. If you look at regional wall motion, which is probably more important because that's in the infarct zone, you can see we have about a 25% improvement in regional wall motion. We've looked at this with more recent studies and horizons. Overall, a 2.5% improvement in left ventricular ejection fraction, and the EF only improves at all in about, the ejection fraction improves at all in about 58% of patients. In the rest of the patients, it can actually go down. So here's, for example, a 49-year-old man who presents early, relatively early, 90 minutes, crushing chest pain, young man, and this is his baseline total flush thrombotic occlusion of his LAD. This patient was in one of our studies. So this is his acute left ventriculogram, which we still recommend gets done, complete akinesis and dyskinesis of the anterior wall, apex, and distal inferior wall. He's having a huge infarct. He's 90 minutes into it. So he has a PCI. It's simple. And here's the results of the PCI. Good TIMI-3 flow, 0% residual stenosis. And 13 months later, he comes back for his study cath, wide open, 0% stenosis, good TIMI-3 flow in the LAD. And remember, this was his baseline LV gram, and here's his LV gram 13 months later. Okay? Total huge anterior infarct, despite reperfusing him at about 2 hours after chest pain onset. So what's going on? Well, first of all, we end up with a lot of heart failure after primary PCI. About 20% of patients get heart failure despite PCI, and it goes up with patient age. And in fact, there's some data to suggest that as we're actually decreasing mortality, we're increasing the number of patients who are living with heart failure because of this issue. So we've got to do a better job salvaging myocardium. And part of the problem is that from the early studies of Reiner and Jennings, once you get to about 2 to 3 hours after an acute infarct with a total thrombotic occlusion of an artery, you get this wavefront of myonecrosis that goes from the subendocardium to the subepicardium, and it's complete. So if you're not reperfusing people within about 3 hours, that's it. The myocardium's gone. Then all your benefit is the so-called open artery hypothesis, which I do think is real. It does provide electrophysiologic stability. It decreases infarct expansion, et cetera, but it's not as good as salvaging myocardium. Now, in the United States, the median time for the last 20 years of patients with infarcts that show up at ERs is 2 hours. So if you have a door-to-balloon time of 60 minutes, you're already down at the bottom of this curve. And we're not salvaging myocardium. There have been huge efforts to try to get patients to come into ERs with appropriate symptoms earlier, and those have been unsuccessful. So there have been lots of ways to try to improve outcomes. The systems of care I've mentioned have improved things, especially in the hospital phase, but can only go so far. People have looked at improving microvascular function and integrity, cardioprotective strategies, both pharmacologic and device-based, and then cell therapy. So the first thing to realize is that after primary PCI, we can get epicardial TIMI-3 flow in about 88 to 90% of patients. But we often don't perfuse the myocardium, because who cares if we're getting blood on the surface of the heart? We want to get it into the heart muscle, and we want to, more importantly even than that, is restore normal myocardial metabolism. So if you look here, this was from Horizons AMI, we had an 86% rate of TIMI-3 flow in a large core lab study, but myocardial blush, which is the angiographic surrogate of blood getting into the capillary system, was only 51%. And if you looked at ST segment resolution, which is acute within 30 to 60 minutes, which has strongly been correlated with infarct size and prognosis, it's down to about 50%. So we're really only reperfusing somewhere between 1/2 to 2/3 of patients effectively. And sometimes you get macroscopic distal embolization. So sometimes it's thromboemboli from that soft lipidic plaque as well as all the thrombus, and you can see it. And this doesn't do the patient any good if this happens. But more often than not, it's actually microscopic. So it's in the small arteriolar and capillary system, so you get so-called capillary block. So here's an autopsy case with this beautiful perfusion of the heart where the LAD's open, but you can see nothing here getting into the myocardium. So this is so-called microvascular obstruction or no reflow. And we took that same database that we had and looked at the impact of microvascular obstruction after STEMI, and just like with infarct size, the greater the microvascular obstruction, the worse the mortality, and the worse the rate of heart failure hospitalization. But interestingly, there's not a direct correlation between microvascular obstruction and infarct size. Some large infarcts, for example, have large amounts of microvascular obstruction and small amounts. And it turns out that microvascular obstruction is an independent predictor of mortality, above and beyond infarct size. Infarct size predicts both mortality and heart failure hospitalization. Microvascular obstruction also strongly predicts mortality. So we thought part of the problem is going to be thromboemboli, and we could do a good job with that with either aspiration devices, thrombectomy devices, or distal protection devices. And all of these have been extensively studied, in particular aspiration catheters. And we can get out 75 or 80% of the time either this lipid-rich plaque or thrombus that would have embolized. So it's got to be a good thing to remove all of that, right? Well, this is the difference between a hypothesis and a mechanistic rationale to do clinical studies and the outcomes. Because when the clinical studies were done looking to see if aspiration reduced infarct size, the answer was it didn't. In fact, one of the studies, it actually increased infarct size, and in the other studies, it was neutral. And then finally, the large clinical studies were done. The TASTE study in 7,244 patients, which primary endpoint of mortality, absolutely no difference in mortality in 7,000 randomized patients with aspiration versus not. And then even larger, the total trial in 10,000 randomized patients, absolutely no difference in cardiovascular death, MI, shock, or heart failure. And in fact, stroke was increased by thrombus aspiration compared to PCI alone, possibly because we're embolizing material as we're trying to withdraw it into the aorta. Small events may or may not be real, but nonetheless, there's not a hint of benefit. So thrombus aspiration went from class 2A in the guidelines to class 3 in the guidelines, despite what seemed to be a great idea. So why did it fail? Well, here's a typical case of thrombus aspiration, totally occluded proximal AD. You restore flow, epicardial TIMI 3 flow, you got a 50% stenosis. This has to be good, right? But the problem is when you look at these cases by OCT, there's a huge amount of thrombus, and we're removing very little by thrombus aspiration. So we're really fooling ourselves. And the angiogram you're going to hear again and again at this course is just an awful gold standard to tell us what's going inside the coronary artery. Now, we've looked at other devices. We've looked at the intralesional infusion of ipsiximab, a 2B3A inhibitor, to disaggregate platelets to reduce embolization. We've looked at stent-based exclusion with this mesh-coated stent. And there's some data, surrogate data, that with intralesional ipsiximab, we might somewhat reduce infarct size, not a lot, but a little, it was significant, and that we can improve ST segment resolution. But neither of these approaches have been subjected to a large-scale randomized trial. We also have other potential promising approaches to enhance myocardial recovery and reduce infarct size. There are a bunch of drugs. There have been about 30 drugs that have failed to do this already, and there's others that are still under examination. There are device-based approaches, hypothermia, supersaturated oxygen, and PICSO, which is intermittent coronary sinus occlusion. Supersaturated oxygen is a long story and may actually get approved later this year to reduce infarct size. And if it does, come back to next year's course, and I'll be talking about it extensively. And then there's others such as ischemic post-conditioning and cell therapy, which for time I can't go into all these. Now, I do want to talk about two of the other hot topics, and the first one is revascularization strategies in patients with STEMI and multivessel disease. So multivessel disease, and we talked about this morning a little, is present in about 40 to 50% of patients with STEMI. And about 10% actually may have simultaneous plaque ruptures. And as we mentioned, in contrast to patients with stable coronary disease, not only is multivessel disease associated with a worse short-term and late prognosis, but these lesions may be more unstable because they more likely be lipid-rich, inflamed, and thin-cap fibroatheromas. So how to treat multivessel disease in the setting of STEMI is very controversial. And there's really three different approaches. One, the most aggressive approach is, say, do it acutely, okay? Fix the infarct lesion, and if all goes well, now go ahead and address the other stenoses. And you could do that with either angiographic-based revascularization or FFR-based revascularization. The second would be, well, if you've got high-grade disease elsewhere, stage them. You should get complete revascularization, bring them back a couple days later or even a week or 2 weeks later. And again, you can do that based on angio or FFR. And the third approach would be, say, look, they were kind of asymptomatic before they came in with their infarct. Let's have a watchful waiting approach. We'll treat them with best medical therapy, and we'll reserve a trip to the cath lab for either recurrent ischemia or maybe a markedly positive exercise test. So we now have 10 randomized trials with about 3,500 patients. So that's meaning about 350 patients each. So these are small or modest-sized studies comparing either of those first two strategies to the watchful waiting approach. And 9 of these have been summarized in a meta-analysis. The 10th, which is compare acute, is not yet in a meta-analysis that I can find anywhere. So I've got those down separately. Now, the first thing is that they all agree on pretty much is that by doing a staged approach early, this could be either a little of it was acutely during the cath lab, most of it was staged after the cath lab. Compared to watchful waiting, you clearly reduce the rate of subsequent revascularization by about 50%. But I must say, this doesn't mean a lot to me because you're revascularizing 100% of one group, and then you're saying, well, I can prevent some of the repeat revascularizations in the other group. So the real question is, can we reduce death or myocardial infarction? So if you look at this meta-analysis here, we have a trend towards lower mortality by the complete revasc strategy, but it's not significant. P-value of 0.18, although it suggests maybe a 20% reduction. And in the compare acute study, which is not in here, you could see, again, 1.4 versus 1.7% one-year mortality. So at least in the right direction. If we look at cardiovascular mortality, though, the data looks stronger. Here we do have a 50% reduction, p-value of 0.003, and compare acute was again 1.4 versus 1.7. And if you look at reinfarction, again, it's all looking in the right direction. These are unstable, potentially unstable plaques, even though they look stable, and about a 38% reduction, p-value of 0.01, and compare acute also in the right direction. So this is now, from all this pilot study and small studies, we need a large randomized trial, and then I think that if this holds up, then we'll start doing this routinely. So there are 2 such studies that are underway. I want you to know about these because these will report out in the next year or so. The first is complete, 4,000 patients with STEMI, primary PCI, and multivessel disease. And they've got to have at least one or more stenosis with a significant FFR, and they're randomized to a staged PCI, not immediate, but staged, of all suitable non-culprit lesions versus watchful waiting approach. And they've got 4-year follow-up, so this is a large study with long-term follow-up looking at cardiovascular death or MI. The second study is the full REVASC study, almost identical size, 4,052 patients with either STEMI or high-risk non-STEMI with multivessel disease, and they're doing staged FFR-guided PCI, and they're making sure it's all within the index hospitalization, whereas you could be discharged in the other trial versus optimal medical therapy alone with a primary endpoint more aggressively of death or MI at 1 year. So these 2, almost 10,000 randomized patients, I think are going to give us the answer. And then the last thing I'll talk about, I'm sure this will lead to some discussion. For those of you who are on Twitter, there's been a lot of discussion lately about cardiogenic shock. Cardiogenic shock are the highest risk patients that we deal with in the cath lab, routinely anyway. On average, people will usually say there's about a 50% mortality in shock, and there's really no evidence that that's changed in about the last 20 years. Now, if you look at large US-based registries, either from the National Inpatient Sample or the Cath PCI registry, the mortalities are a little bit lower, maybe around 40%, but that's all based on definitions. Now, this national inpatient sample of 158,000 shock patients between 2003 and 2010 would suggest that in-hospital mortality may be getting a little bit better, along with increasing use of, again, reperfusion therapy, mechanical circulatory support, and other approaches, but really not so much. The same data from the Cath and PCI registry in 50,000 patients suggest we're not making any progress at all. So whichever you want to believe, regardless, mortality is very high, and in true cardiogenic shock, which I would say is 80 millimeters of mercury or less, and requiring pressors and support, the mortality rates are 50% or higher. Now, what could be done? Well, one thing that we think is that most of these patients have multivessel disease, and this may be the place where acute, immediate multivessel intervention really can make a difference. And there was registry data that went both ways, suggesting that if you did it, it'd be helpful, not helpful. Well, the culprit shock was reported at TCT last year and published in the New England Journal. Big study, 685 patients with shock due to either STEMI or non-STEMI. Interestingly, a third of the patients had STEMI. Were randomized to immediate multivessel PCI versus culprit lesion only PCI, with or without staged PCI of the non-culprit lesions. And that was done in only 17 to 18% of the patients. So it's really, let's treat everything, complete revascularization acutely versus only the infarct vessel. This was a very high-risk population. 53% of the patients were resuscitated. The EFs were 32%, 90% were on pressors, 2/3 had triple vessel disease, et cetera, et cetera. A quarter had chronic total occlusions. They only used mechanical circulatory support in 28%, and we'll discuss that, I'm sure. The mean amount of contrast took 250 cc's in the complete revascularization group versus 190 cc's in the other group. And their primary endpoint was death or renal replacement therapy, meaning dialysis, at 30 days. And you can see this was paradoxically higher in the multi-vessel PCI arm. And this was a shock to everybody. I think most people wouldn't have been surprised if it didn't work, but the fact that it actually worsened prognosis, p-value of 0.01, a 20% increase, due to higher rates of death and higher rates of renal replacement therapy, was surprising to a lot of people. We don't know why this is yet. We're waiting for more data. Maybe it's the additional contrast and contrast nephropathy, but maybe there are other factors as well, including distal embolization from other lesions, so worsening the situation. Now, the big thing that we've been debating lately is mechanical circulatory devices and cardiogenic shock, and we've gone from intra-aortic balloon pumps to Impella. We've got 2.5, 3.5, and 5 liters per minute of support, to ECMO, to the tandem heart, and in Europe, a new device called the IVAC. And everybody was using balloon pumps and cardiogenic shock, and it was class 2A in the guidelines because of registry data until the IABP Shock 2 trial. And that was a 600-patient randomized trial with shock, again, high-risk shock, and you can see there was absolutely no mortality whatsoever in patients treated with or without a balloon pump. And this led from the intra-aortic balloon pump use being downgraded from 1C in the European guidelines to class 3. That is, may cause harm or at least no evidence of benefit. And balloon pump use is declining, although not being eliminated. Now, in terms of the LVADs, okay, where you get much more support and you can get complete circulatory support, we've got almost no data whatsoever. There's 4 little tiny randomized trials, 144 patients, and they haven't shown benefit yet, haven't shown real harm, but the confidence intervals are usually wide. So we do need randomized trials in this, and there's one randomized trial that's ongoing, worth speaking of, called DANSHOCK, which is taking a total of 360 patients with STEMI and cardiogenic shock of only up to 12 hours duration, which is good, and randomizing them to either the Impella CP device versus conventional therapy. And it'll be at least 2 days of support, with a primary endpoint of mortality at 6 months. This study's only enrolled about 100 patients. It's taking a long time, but hopefully they can complete it because it's critically important. So in summary, STEMI comprises about 25% of all ACS admissions. The incidence is actually falling. We're converting STEMIs into non-STEMIs by medical therapy. And the case fatality rate is also markedly decreasing, explaining much of the improved survival in patients with coronary disease. This has been our #1 success story in all of the field of interventional cardiology, and you should feel great about this. We're saving tens of thousands of lives. Rapid reperfusion with primary PCI saves lives and prevents recurrent ischemia and refarction. The faster the better, but there may be diminishing gains. The evolution from balloon angioplasty to bare metal, then first and second generation DES, has reduced recurrent ischemia and restenosis, but not clearly death or myocardial infarction. And a large part of the large reason is that myocardial salvage is suboptimal in STEMI and mortality remains high in cardiogenic shock. New strategies are clearly required to reduce infarct size and further improve prognosis.